Great. Hi, everyone. Welcome to our office hours. Thank you for joining us. Um, Today's panelist is Dr. Phillipson and Dr. Greeley, and we also have two speakers, Dr. Hart and Dr. Abdulaziz. An important disclaimer, no PHI may be shown during these case studies. Yeah, to get us started, our first case will be presented by Dr. Phil Hart from Ohio State University.
Thanks, Ava. Thanks for letting me crash the party here. It's my first time, and so maybe I'll just ask for orientation. What is the typical format like? What would you like from me? What are the time boundaries?
Sort of like pseudo shortened grand rounds. So,
Okay.
you can start the case, we'll interrupt if necessary, but usually give you a
Yeah.
few minutes to tell us what we need to know. And Dr. Greeley always asks the best questions.
Okay. Perfect. That's great. So thanks. So my name is Phil Hart. I'm a gastroenterologist at Ohio State, and my clinical practice is singularly related to diseases of the exocrine pancreas. And so just brief word of context. This case is a patient who I met in the office for the first time a few months ago, and at the time of our initial visit, I was just trying to get lots of information from her, and there were a number of things that just seemed a little cognitively dissonant that just seemed to really stick out. I reached out to Kathleen Dungan, who's one of the primary endocrinologists that I work with at Ohio State, and yeah, basically led to this conversation related to exocrine pancreatic insufficiency in the setting of patients with monogenic forms of diabetes. She kind of shared a few anecdotes from her clinical practice, and which triggered some more questions. And then she referred me to the group. So I'll go ahead and go through the case, and then we can hopefully discuss things further. As a disclaimer, this patient does not follow with an endocrinologist at our office. So a lot of the diabetes information, as you can see, related to testing, that sort of thing, is not contemporary and it's not fully complete. So I apologize at the outset for that. But so the patient currently is 75 years old. She was diagnosed with diabetes, from what I can gather from her records and self-reported history, about 15 years ago. Although I don't have the exact BMI, she's lean. Her current BMI is around 17, and she's really at her usual adult body weight. Again, I don't have any of the diagnostic parameters, and there was no DKA at the time of diagnosis, as far as I know. The only C-peptide that I was able to find in her outside records is shown here from a couple years ago. I don't even know if that was a fasting value. So I was able to track down a couple autoantibody levels for the GAD65 and anti-islet, which were negative. You can go to the next slide. So as it relates to her current medication, she's on nateglinide at the dose range shown there. She'd previously been on metformin. It wasn't completely clear to me why she was transitioned off of that. It looked like there was some mention in the note that the patient had requested to transition to a different medication. As I mentioned earlier, she's lean, and that's usual for her. Her most recent hemoglobin A1C from within the last 1 to 2 months, 7.6. I was seeing her actually in our pancreas clinic because she had an incidental pancreatic cyst, which is just extraordinarily common. But when I was asking and poking around, she also had some mild abdominal symptoms, abdominal bloating, periodic loose stools, and had previously had a fecal elastase level that was borderline. It was low, I should say. It was around 120, and clinically I felt that she met the diagnostic scenario for exocrine pancreatic insufficiency, particularly when combined with some of her imaging features, which I think we have a couple snapshots of those. As it relates to her family history, there is a family history of diabetes in her mother. It's unclear to me whether or not her mother had had any preceding genetic testing or the age of onset for diabetes for her mother. Next slide. So again, this is all from sort of nosing through her records. I was able to find this was a report from another provider, so not the actual test report to understand what all was examined in 2018. But she was noted to have a pathogenic variant of HNF 4A, which was something that she was aware of. One of the things that struck really caught my attention was when I looked at some of the old imaging reports and then did some more digging, found the old images from an MRI scan that she had had, and then updated a CT scan, which is shown in the top and bottom respectively. Is just that there's really pretty extensive atrophy of the pancreatic parenchyma. The picture at the top, if you're not familiar with, is an MRI. This is a T1 sequence, and typically, I'll see if I can annotate. Do I have the option to annotate, Ava? No, but okay. I'm not seeing any buttons for it, but typically, the color of the pancreas, we expect it to be as bright as or brighter than the liver, which is seen on the left side of the screen. But it's certainly not same intensity, number one, but then also there's a lot of fat replacement. So the parenchyma is just absent. And then on the CT scan at the bottom, which is done without IV contrast, again, there's just really yeah, I don't know how to be more descriptive. We refer to it as fatty replacement of the gland. So this is seeing her imaging and kind of looking at everything together is really what triggered the question for me, initially to PubMed, then to my local endocrinologist, and now to the group, is whether, exocrine pancreatic insufficiency with this degree of fatty replacement of the gland is something that you've seen, number one, in your clinical practice for individuals with this type of monogenic diabetes, as well as whether or not this is something that you see as sort of a common feature of the other forms of monogenic diabetes. The one that I'm personally familiar with is used to be MODY type 8 or the pathogenic variants of CEL. I have a couple patients who I follow with that, and this imaging looks almost identical to that, which is one of the things for me that sort of triggered the question. So I think that's all that we have from a slide standpoint. But again, happy to provide any more details or context if that would be informative.
No, that's great. I think it's interesting. Dr. Abdelaziz also has an HNF4 alpha case, so we can have two of those today. Um, so just, to back up a little bit, and interesting that you mentioned CEL, so we can talk about CL a little bit too and make sure we understand those because those are very rare and mostly, hard to establish. But we were in touch very much with Paul Nolsted's group in Bergen
What a
and
good boy.
who really put that on the map.
You're
So
being a good boy.
okay, Deb, you need to mute if you could. There you go. So I think that the HNF4 alpha in general. So I don't know if so. Bala is on. Bala is our research associate who works with the classification group, and we just want to be sure that RH136 trip is in fact truly pathogenic. Sometimes the chart says that it is, but it actually was reported as a VUS, and so this one looks pretty good and it does explain a few things. So just to put in the context, so for us, the most common monogenic form of diabetes is glucokinase MODY2, and the second most common is HNF1 alpha, which is the transcription factor in the same pathway as 4 alpha. And then 4 alpha is like a distant third in our own registry. So we don't have many cases. I think Ava can tell me, but it's like maybe 30 people that we've tracked. Um, and even just every time we review it, because the transcription factor is early in the uh, program, you might say, for the pancreas, and so the entire pancreas is part of it, and then the islets in particular. So there could be both a glucagon and an insulin insufficiency. The glucagon hasn't been reported very much in 4 alpha. But the connection to this sort of impressive pancreatic insufficiency is not well reported. It's certainly possible you could do that, and it's also possible there are other family members. We'll come back to that in a moment. So it's extremely interesting in that sense. Now, she was probably switched because metformin is only likely to give her diarrhea in this situation. Usually, I think about metformin as a drug for insulin resistance. It, although it can work on people with sort of normal insulin sensitivity because it mostly works in the liver. And my almost joke is that I think about it as a mild mitochondrial poison. So that the fact that it helps in diabetes at all is remarkable. But in monogenic diabetes, we like to use sulfonylureas when possible. And so it's interesting that she's on etaglonide. Oftentimes in 4 alpha, the sulfonylureas don't work either at all or very well. She is so lean with a BMI of 17 that it's possible a little bit of um, oh, a little bit of insulin secretion goes a long way. So we actually have almost now 100 4 alpha patients. So clearly I wasn't paying attention to our own registry. So I think then the question is how many of them have pancreatic insufficiency, and that I'm not sure about. So it's something that we see, and if you do a quick literature search, it'll say that it's likely to be connected, um, but it hasn't been completely established in older people. So what's interesting also, just a few more comments, then maybe Dr. Greeley or Dr. Abdelaziz would like to say something, or Bala. Um, so the mom probably had the same thing. These are dominantly inherited, so heterozygous dominant mutations all the way around. Um, the the question is, does she have children? You didn't mention that, but each child would have she had no children. So each child would have a 50-50 chance of having it if she did. If she had SIBs, they would also have a likelihood of the same 50-50 chance. So that would in principle be interesting. In 1 alpha, we worry about uh, usually unmeasured cardiovascular risk. So some of the LDL subpopulations, which might not show up in a simple lipid panel, can still be high. So we have been recommending, I mean, the field, other groups who study this in other countries are thinking that we should be giving people statins with 1 alpha, so MODI 3. This is less defined, but HNF stands for hepatic nuclear factor, so it was originally cloned from a liver cDNA library back around 1995-ish, and that was where it was found. But interestingly, it isn't as devastating for the liver as it is for the pancreas and the islets. So it does sound like nitaglonide is a good approach as long as her A1C these days is reasonable. Pancreatic replacement is the way to go. And maybe maybe that's enough for now. I mean, I don't, Siri, is there other things that we should be mentioning in this context?
Well, we could mention that the the MAP T1D group, we've had a collaboration with Vanderbilt where we've been looking at the pancreas of MRI, or the MRI of pancreata and people with monogenic diabetes. So kind of the exact question you were asking. And I was just looking back at the data. The paper's going to come out soon, and then we could share it with you. But I don't think anyone was quite as severely affected as your patient here. And I can speculate on some of the reasons, probably the biggest one being her age, where I think most of the people we were looking at were not this old. Um, and there's a lot of uncertainty because there's so few cases so far. But of course, there's going to be a lot of variability. Even in the small number of cases we looked at, there's a pretty large amount of variability, where the main thing we are focused on is the pancreas size. But basically, most monogenic forms have at least slightly smaller pancreas than normal, but the 1 alphas and 4 alphas that have a pretty good preservation of beta cell function, the effect is less pronounced than in other types where you get more insulin deficiency, such as insulin gene mutations. And and 1 beta, if you've ever heard of that, has kind of been known uh, classically to have people where sometimes their pancreases are smaller. So that those ones were more affected. Um, so it's worth trying to gather more data, but particularly when they have the clinical manifestation of the exocrine pancreatic insufficiency, which is not, it's just something we've kind of been interested in, but we've not truly focused on. Um, and I don't know if Ava or Michael recollect if we even ask a specific question about that in the registry in general. I can't recall. I know it's kind of like on the list of other features, but at some point it would probably make sense for us to try to get back to people and investigate, because as I'm sure you recognize as a GI person, the people with pancreatic insufficiency can go on for a long time without a diagnosis, and they can have kind of variable symptoms, and it makes you wonder, like, how many 1 alphas or 4 alphas are there out there who might have at least mild EPI and just don't know it. It's definitely worth looking more into. But I wonder if your patient's age is playing some role here. It's interesting that her diabetes wasn't diagnosed until she was 60.
Yeah.
That's that's very unusual for the 1 alphas and 4 alphas. And it
Mm.
makes me wonder if I mean, she's so small and thin, that maybe she didn't need much beta cell function. Um, and that C-peptide recently is still pretty robust. So it's a little bit unclear to me why she would go that long.
Yeah,
There's
so
a
Um,
that
lot of
that's
things.
worth mentioning. So, and I'll
Yeah.
just add a couple things. So it's some of we have seen rarely that the people are mosaics. So it would be interesting to dig out the original report. I mean, Bala got back to me and said, it is even now that particular variant is considered likely pathogenic. So it means there isn't quite enough, and probably this was submitted depending on what company, because one of the things we always try to track is which company reported the genetic testing. So some of them are better than others, and some of them are pretty good about reporting, uh, exactly what kind of variant it is, and then they report it to ClinVar or one of the other repositories, and then it's added to the compendium that would push it over into pathogenic or likely pathogenic. But I totally agree with Siri that, and I didn't mention that, and I should have. They know that 60 years old is it's very late. I mean, the whole definition of MODY, as you may probably know now, is onset usually before the age of 25 was the original, and we've extended it, say 30, 35. It's possible the low BMI, but then there's a chicken and egg question with the BMI. Was she always this small, or because of her pancreatic insufficiency, did she
Yep.
have malabsorption for decades and lost weight? So those are some of the other considerations. And I guess the fertility, I mean, did she not want to have children, or did she try and not? So those
Yeah, I
are,
didn't ask. Yeah, that's a good question. So a couple of things I'll add, and then a question to sort of riff off of what Siri was sharing. So Mitch Ramsey has joined the call. He's another one of the pancreatologists from our group at Ohio State, and he has an interest with patients with cystic fibrosis, GI manifestations as pancreatic, but also the non-pancreatic manifestations. So he'd introduced me to the pancreas imaging and CF, and this like really extensive fat replacement. This doesn't quite look like a CF pancreas, but it's just something that's really dramatic when we see it. One of the thoughts was related to her age as being a contributing factor, and certainly we do see age-related atrophy of the gland. What I'll say is that with that, though, we generally don't see the fat replacement. It's a thinning in the anterior posterior dimension is more typical that we see with changing over time. But I guess one of the questions that I would pose back is and this is what our endocrinologist was kind of raising with me is do you think we should be doing, imaging of the pancreas, or based on the results from the study that you're getting ready to release, do you think that all patients with monogenic diabetes should have some type of assessment of exocrine functions, either fecal elastase, which has all of its wrinkles, or what I would advocate for would be cross-sectional imaging of the pancreas, if that's the goal to evaluate that.
Where we're getting there, the people who sell Creon definitely want you to do that.
Yeah. Well, that's a whole separate story.
Yeah,
That's
right. But
take more
that's
than an hour to debrief on
right.
that. Yeah.
So they want everyone with diabetes to be evaluated for pancreatic insufficiency. So, and occasionally we see it in type 1. But this group that, Siri has been involved in at Vanderbilt is very interested in imaging early type 1. And so one of the papers already published is the fact that those people have smaller
Right.
pancreata in general and have a higher incidence potentially of insufficiency. But Siri, to talk about, we have this amazing family with an insulin gene mutation and a CF mutation. So is it possible your patient has both?
Hmm.
I did I did wonder about that too, if there might be another genetic component. And I also wondered like the other things that affect the pancreas. Do we know if she had a history of alcohol use or anything like that?
Yeah, she didn't have any alcohol or cigarette smoking, which would be the two environmental ones, and there's no family history of disease of the extrinsic pancreas, either pancreatitis or cancer, for that matter.
Yeah, it's interesting, but I I can't say that we're quite there yet of like screening everybody like across the board with monogenic diabetes, at least not with imaging and probably not even with fecal elastase yet.
Mm.
But I certainly think, symptom-based screening still makes sense. I mean, I wonder for you, I mean, we're not exactly experts on the EPI stuff, but to have a diagnosis, you still need symptoms, like regardless of what the MRI looked like, right?
No, no. So
Really?
one of the key things that, as we're talking, that I would, and Mitch is throwing a couple other objective parameters that could be entertained or considered, that I've been using in my very, very small group of people with monogenic diabetes, known or suspected. But one of the key things to keep in mind with EPI is that even in patients like with a total pancreatectomy, just to throw out an extreme example, not everybody will have symptoms. And one of the primary reasons for that is that people will either consciously or subconsciously modify their dietary intake. So either they'll just eat small, they'll nibble and kind of graze throughout the day, and they'll avoid large bolus of food, or they'll eliminate or adjust the amount of fat that they eat. So symptoms, unfortunately, are a very poor indicator for EPI. If they're present, especially if steatorrhea is present, then okay, yeah, that's clear cut, very specific. But anything short of steatorrhea is unhelpful, to be honest. If they're present, then 100%, would advocate for lab testing, stool testing, cross-sectional imaging. But even in the absence of symptoms, um, I mean, part of me is curious, but I also think that from a, exocrine perspective, that it would clinically be a reasonable consideration. Again, that's why I'm really interested to know what your, clinical experience is like with much larger, I mean, admittedly still, 100, but much larger, collection of patients with this and other forms of monogenic diabetes.
Well, like I mentioned, the one betas, you'll definitely have many of those who are being treated, and I think there you would have a rationale for absolutely like imaging and screening like you talk about. But with one alphas, four alphas, and many of the other types, the more rare types, I don't think we have enough information. And with the one alphas and four alphas, it's not like a thing that has been known. And I say that because I understand that there might be people more than we realize who might be affected, but you would think if it was affecting a significant population or percentage of the cases, that it would be something that we would know at least a little bit, like there would be a hint of it. So my guess is that it's a fraction of patients who are being affected, and possibly based on your case, it might be more of a risk as they get older. Um, I certainly would encourage you to publish this case. It's definitely unusual and worth, helping people to think more about. I don't know if you referred them to join our registry as well.
I'm happy to do that if she's a very let's say, a very curious woman, which in part led to the diagnosis, of monogenic diabetes when she was over 60. Is she was personally advocating for genetic testing. So I think she'd be highly motivated to do that. If Ava or somebody could just provide me with the contact information, I think that would be a really good fit for her.
Yeah,
Yeah,
it
and
is interesting that the sulfonylureas work less, as I said, in 4 alpha than in 1 alpha, and they sometimes stop working. We the technical term is they poop out, and then uh, where the insulin is really the best. Although there are now a couple of papers, and some of our collaborators at Cleveland Clinic, who now at Michigan, are using GLP-1s and either alone or with sulfonylureas in a lot of it was in 1 alpha, and now it's in 4 alpha also. And the one case report from Cleveland Clinic, and the fellow David Broom went to Ann Arbor. So they're continuing to advocate, and the group at Mass General also is advocating GLP-1. So it's very interesting that they do respond, and you can almost bypass the absence of the transcription factor. Whether what that would do for her acid or pancreas, I don't think much, but there's no reports on that. So I think it's a great case. I definitely agree with Siri that you could put it out there in one way or another. Just to get back to the CEL, I think I don't know if you published those 2 cases, but there was a recent paper from the Bergen group, Paul Nolstedt in Bergen, Norway, on what variants in CEL actually lead to that form of MODY, or really it's not MODY in our minds, it's really pancreatic insufficiency where the beta cells go away because there's no CEL in the insulin secreting cells. And he's very adamant about which sorts of variants and not so much point mutations, but deletions of the gene and a few other odds and ends. So we could send you that most recent paper if you haven't seen it, and you could see whether
Sure.
the 2 books you have match up to the CEL story.
Yeah, the one that I have does not. It was a novel, variant that um, I think the read from the company was, a VUS, but then phenotypically the patient fits the syndrome. Her father, also had it, also phenotypically similar as well, and so we felt clinically that it was behaving pathogenic. But,
yeah, and with those unusual kinds of cases, my public service announcement would be we would anyone with any variant absolutely qualifies to join our registry, number one, so we can try to, kind of catalog all of this and have the data available. But the other is to publish as well, so that it's there in the record. And that helps with one of the other kind of things that many of us do is this work of gene curation and variant curation. So when you get your genetic test report back of VUS versus, pathogenic, like each case in these situations actually really adds a lot potentially and can actually push it towards being more sure about pathogenic or not. And the cell variants, if it was a different one and you have such a suggestive phenotype, that would be, really pretty different and would be good for people to know about.
appreciate it. Okay, great. Well, thanks so much for your time and the input. Appreciate it.
Yeah, great case. Glad to
Thank
have you
you. Yeah,
join
we
us.
appreciate it, and we certainly love to hear about these cases. And as I say, I was just looking for that reference just now, and Actually, I'm not sure I'm finding it.
I
So
just want to be clear that the party is open. You're not crashing. You're welcome to join anytime anyone is. So that's what we're here for.
But I may eavesdrop for this next one just to see what I learned.
Hey, this is Chelsea. I can't figure out how to text because I'm on my phone today for the chat. But I'm just curious what your comfort level is in using a GLP-1 with somebody whose BMI is 17. Like in general, is that something you'd still feel pretty comfortable with or not?
Can I make a quick comment? I know I'm a pediatric person, but this has been coming up more often, and my quick response is at the lowest doses of the GLP-1s, they really don't have as much of an effect on appetite suppression and weight loss. And it's where we tend to remind people that GLP-1s were originally created to because of the incretin effect on promoting insulin secretion and the effect that they have on the beta cells. And then the whole thing about weight loss kind of came later. So the short answer is you do have to be mindful of it, but just because someone isn't overweight doesn't mean you absolutely can't use them. So you might start at a very low dose, just be watching the weight and appetite and everything carefully. And I've personally recently had a family with 1 alpha who were on sulfonylureas and not doing great. And when we added a little bit of GLP-1, they did great. And I hope I'm not stealing from Dr. Abdelaziz's case because I'm curious, and we might talk more about it with this.
thank you again. So we hope to stay in touch. And if things change with this patient or it turns out there are other members of the family, then that would also be very interesting. And also thanks Dr. Ramsey. We definitely agree. I think in some of the people I see with diabetes who have pancreatic insufficiency in the first place, those are exactly the things that we do. So we work closely. So that's great.
And also, Chelsea, glad to have you joining us today, and thanks. That's a great question.
Hey, am I good to go? Thank you. Thank you so much for inviting me. Dr. Phillipson knows how excited I am to be here, and Dr. Greeley and Ava, thank you so much for your help with the slides and with everything. So today, perfect. I would like to present my patient. I actually saw her one time in clinic only a few months ago. She's 44 years old. She was diagnosed with diabetes at age 36, but she has known that she's had prediabetes since her early 20s. She also was diagnosed with gestational diabetes requiring insulin for 3 out of 3 of her pregnancies, and those were in 2014, 2017, and most recently in 2019. Following her last pregnancy, her ODTT was actually mildly high after her delivery, but because of the pandemic, she never really followed up until 2022 when she got her A1C checked and it was in the diabetes range, 7.6%. At the time, her BMI was 25.7. She never had DKA diagnosis or even afterwards. Her antibody were checked in 2022. She had her GAD antibody that was negative, and when I saw her recently, 2 or 3 months ago, I checked the IA2 and the zinc transporters, and they were also negative. I actually went through her chart and saw that her C-peptide was checked again in 2022, and that was 2 with a concurrent glucose of 104 on that sample. I don't know, am I able to change the slides? Okay. Her current medication, she's actually on Mounjaro 12.5. As I mentioned earlier, she was on insulin during pregnancies and briefly was on metformin between her first and second pregnancy. After her diagnosis, she was briefly on semaglutide, Rybelsus. She did have side effects with those. She had a lot of GI, and recently she's been doing well on the 12.5 of Mounjaro. Her current body mass index is 20.3. I did talk to her about maybe a dose reduction because her A1C is 5.1, but she's quite, pleased with where she is right now in terms of her weight or her diabetes control and her numbers. Additional medical history, this is also a new diagnosis for her, is elevated lipoprotein little a. One of the things that struck to me is someone with a BMI of 20.3, her LDL was 150s, despite being on rosuvastatin or Crestor 20 milligram that she was actually taking. But the lowest LDL recently in her chart was 130s. I did not dive into the cardiac history of her family, but I know that her mom had dementia, was diagnosed with dementia. Rest of the history. Family history of diabetes. So father, I did when I asked her again. Dad has known that he has had pre-diabetes for several years, but the diagnosis of diabetes was made in the last 3 months. So this is very recent. His BMI was 25, and at the time he was started on basal insulin, and the dose has been reduced as his numbers improved. His endocrinologist described his diabetes as 1.5 diabetes. That's what they've been told. But he's doing better now. Of note, her paternal grandfather, and also she has 3 aunts with diabetes, but she reports that they have alcohol use disorders, and that's what they attributed the diabetes to. Mother did not have diabetes. She has aunts and uncles, and they don't have diabetes. Her uncles have diabetes, but not her aunt. She has 2 siblings, no diabetes as well. She has 3 children, as I mentioned earlier. They are 10, 8, and 5. Of note, her youngest child was large for gestational age, and I have here his weight was 11 pounds and 3 ounces. And she recalled him having hypoglycemia, needing to be treated for several days after his birth. She is getting all of her children tested for HNF4 alpha. Well, I think I just gave away the diagnosis. HNF4 alpha as well through their pediatrician. Okay, and this is the result of her genetic testing that we got through UChicago. It came back positive for HNF4 alpha, likely pathogenic variant. So for me, the questions that I had is her family history. Yes, she has like several, uncles, but when she was first seen at the time of her diagnosis, none of her parents had diabetes. So I think that's probably what led for her not to be tested at the time. But her BMI and the fact that her child was large for gestational, that's what kind of made me pursue this testing. She's currently, I would say, very well controlled on a GLP-1 analog. And the biggest question that I had is, and I think it was partially answered, we think that she'd do better on a sulfonylurea, but I mean, she's 4 alpha. Should I just keep her as is, other than just perhaps reducing the dose a little bit if she's interested? What else can I do to help her? And obviously, screen her family. And I'm very interested now about her. I'll check her vitamins as well. And as Mitch mentioned, all of her, check for her exocrine function. And microphone is yours for questions.
I don't know if you want to first, Siri, this.
Can I first just clarify that I'm not crazy that both of these patients had the same variant?
Yeah, it is.
They're a little different. They're similar, but a little different. That caught my attention too.
Yeah, so it's both ARG trip, but it's a different residue, right? This is 114. What was the other one?
It's 136.
Yeah.
Oh.
Both are same only, with the 2 different nomenclature.
They're 2 different nomenclatures, but they are the same variant. That's what Paula is saying. Yeah.
Oh, because different.
There's a weird transcript thing with 4 alpha in particular, and which reference sequence you use, and it gets a little complicated. But
Excellent.
yeah,
Yeah.
I think they have the the same variant, which is
Are they related? I don't
well,
know.
Well,
they're
it wouldn't be
you
the
know,
first time that's happened, but
it's possible, but of course, as Bala I think mentioned to Lou, this variant has been seen a few other times, but these cases certainly add to our understanding. And I guess one comment I would make about what Sarah noted, the the child with being large for gestational age is a very suggestive feature, and I'm very impressed that anyone doing adult endocrinology would think of that. And but it's like part of Lou's mantra about family history of diabetes being so important. I mean, the family history in general is very important in helping you think about what kind of diabetes the person has, and it's not just the generations before, but the next generations and what's happening with them that also can be highly relevant. So, in terms of testing the kids, one quick thing I would point out is that the whoever's trying to get the testing done, they should really be asking for testing for this specific variant, like not just testing the whole gene, but for so you're looking for it's like known familial, variant carrier status kind of testing, and that tends to be significantly cheaper. And if they go through the lab where it was already done, that also tends to be a little easier. Although it all, of course, all still kind of depends on insurance coverage and that kind of thing. But we're happy to kind of help people navigate those kind of things, even if we can't necessarily do a lot of testing right now because of our funding situation. We're still happy to have people join the registry, and we can help to guide with that kind of thing.
but yeah, and sorry, your observation. So I didn't realize. So there are 20 amino acids off, and I don't know. Bala is listening. So there's two different standard cDNAs, then and the different so we don't know which company is which. Who did you use for this one, Sarah? Which company is this? Is this
I
us?
did it through U Chicago. Yes,
Oh, this
that's
is
yeah.
so this is our
Yeah.
U Chicago clinical lab, and Phil, you would have to figure out where that was sent.
Yeah, I don't have that yet.
And maybe it may be lost and that the record was somewhere else. But it is interesting that it becomes challenging and so Bala, is this a question of is there like a 20 amino acid change in the two cDNAs? Or actually 22, I guess.
Yeah, around 20 amino acid difference. Yeah. There are one more report, it is showing arginine 127 tryptophan also. uh, the same.
Maybe, yeah, so it becomes challenging to match things up. But in this case, we have seen, similarities by descent, even though they're not actually, close family members. There's, they're cousins or distant cousins. But it certainly looks like, so I agree with your inclination to test vitamin levels and to see whether this family has I mean, that would be extremely informative. It's possible you could publish the families together, that the same mutation essentially has two very different phenotypes. I mean, that's an interesting idea. So that could be an illustrative case right by itself. It's possible we could do imaging on your family with the protocol that we have here with series protocol to do both sides, and it would give us some estimate of a fatty replacement when we do that as well. So that could be something to catch up in addition to doing the enzymes and lipase and so on.
Yeah. And getting back to that question about her the dose of tirzepatide, um, I think given the the A1C and her current BMI, I agree with your inclination that she doesn't necessarily need to be on the high dose, but on the other hand, if she's happy where she is and it's a normal BMI and she's not like underweight, I don't think it's necessarily a bad thing to be on the higher dose. I think her case is uh a little different than what the question Chelsea asked about people who start off already with a really low BMI, because her BMI was a little on the high side to begin with, so that made it a great choice to start with. And then one more comment about the GLP-1 approach in these 1 alpha and 4 alpha patients, in addition to this, or in addition or instead of sulfonylureas, is the cardiovascular risk issue, which I think is probably less well understood for 4 alpha than it is for 1 alpha, but with your, the lipoprotein a little a and
Yeah.
the lipid levels and those kind of things. I mean, the point being there's still a real cardiovascular risk in Modi, even though, kind of, I think what a lot of people think of when they think of Modi is like, oh, it's a mild diabetes. They only need a little bit of treatment and then they do great. The reality is their diabetes can often be very well controlled, but they still have other risks, including the cardiovascular risk, which is especially well documented in 1 alpha. But I think with 4 alpha, there's still a risk too. So point being that the medications that help to lower cardiovascular risk really that's another reason to think about incorporating.
I have a question for you, Dr. Phillips and Dr. Greeley. So, with the natural history for HNF4 alpha and 1 alpha, it's thought that a good percentage, maybe up to 30%, would end up needing insulin at some point. And I don't know if you're thinking maybe a contributing factor is them being on sulfonylureas versus if we're trying to get them controlled on a GLP-1 analog, for example. Because even in people with, I guess maybe we don't know because not everybody's been tested, but even with people with type 2 or LADA, if they are, or late onset type 1, if they are on a sulfonylurea, they end up needing mealtime insulin sooner, for
So
example.
you make a good point. I mean, in the beginning, when the sulfonylurea sensitivity was described, and so that was severe in 1 alpha, in HNF1 alpha, that those people got, and to this day, get hypoglycemic in the beginning when given sulfonylurea. So the lowest doses, that's what Siri was saying, the lowest doses of sulfonylurea can be effective. But is the sulfonylurea causing them to need insulin more quickly? I think that's what you're asking.
Yeah.
And maybe, but there are not enough people to know. And it may be that that's why our colleagues Miriam Udler and Sarah Cromer at Mass General are tending now to start with GLP-1s in 1 alpha and 4 alpha straight away and avoid sulfonylureas if that works well. In someone who's really low BMI, I would imagine going with a once a week GLP-1 low dose to get to Chelsea's question, and insulin. Maybe a basal insulin plus GLP-1 is possible. And if we do get to see once a week insulin, which is in testing again, that could be a choice. So once a week insulin, once a week sulfonylurea, and I'm sorry, once a week GLP-1, and you have a therapy that could be the easiest and very effective, depending on how you feel about injections. So we don't know enough about those things. But Siri, what do you think?
Well, one thing is, like you're alluding to, the funny thing is we don't really even understand very well the mechanism of diabetes in 1 alpha and 4 alpha, because these are transcription factors that are doing a lot of things. It has to do with how the pancreas and the islets develop in the first place and how well do they function. But I think part of the thought with the sulfonylureas is that the cells are there that are making some insulin, but they're not very responsive. They're kind of sluggish, and you're just kind of pushing them because maybe their glucose sensing isn't very good or whatnot. And the classical patients are responding to a tiny dose of sulfonylurea. And so that suggests that it's more like the sensing that's often they not knowing when to produce insulin, and you're helping them to produce insulin, and that's a good way to do it. But you're not necessarily, the I think the way I sometimes think about sulfonylurea as long term as you're like whipping the cells to make insulin and like they're dying over time and whatnot. But if you think of these patients who respond to a tiny dose, um, I think the way the Hattersley team in Exeter would think about that data, and they have, when they tried to go back and get like all these families that they had insulin sulfonylurea, there was even a concept that the ones who started sulfonylurea earliest and did the best with their diabetes control, they may have a much better long-term outcome and may not even need insulin as much because there was a better uh, uh, prospective kind of treatment earlier on that helped the cells to stay healthier. Um, but there ultimately isn't enough evidence to say about that. But the 30% insulin, or like that has more to do with what are even the choices you're talking about with that data, because that was before GLP-1s. I think that's the main point I would make there. That if all you have is sulfonylurea, insulin, and metformin, then many of these are going to eventually fail metformin and need something else, where before it was insulin. I think now there's growing data that the GLP-1s make a heck of a lot of sense. And I think with what we know about their potential benefits and the potential risk of the sulfonylurea is that you might try to minimize the dose of the sulfonylurea and also minimize the dose of the GLP-1, particularly if they're the weight issue. But by having some combination, if they can do well with that and not, need the insulin, then of course that's great.
Yeah, I have several 1-alpha patients that were starting to have a higher A1C on glyburide, or we was using ripaglinide, uh, and adding one of the newer GLP-1s, either sema or tirzepatide, restored the sensitivity to sulfonylurea. So they were able to do well on lower doses. But in 4-alpha, a lot of the folks that I've seen, and it's not many, don't respond to low doses. So you're going to 5, 10, 15 milligrams glyburide equivalents per day, and that suggests that they're not very responsive. So it's exactly what Siri was saying. And that in which case, that's the thing that the Cleveland Clinic group did with David Broom and Dr. Pantalon, that they, in that HNF4 alpha family, they did better adding, I think they were using semaglutide at the time. So there's just the numbers are small. I mean, that is one of the reasons we're doing these office hours is we want to get the word out. We want to pool cases. We have, just to put another, as Siri is saying, some of this is advertisements, but we do have a group that we're calling Predict, which is putting at least the first 10 groups around the country together to pool cases in a way that preserves individual ownership of the various cases, but allows us to do searches like this, where even a few hundred cases are not enough to understand what's going on. But I think it is remarkable that these two cases are the same mutation. It suggests things to do on both sides. And sorry, you may be able to do pancreatic imaging and vitamin studies on your patients. That would be terrific.
Yeah.
And
Mhm.
oh, just one quick additional point related to what Chelsea said about the GLP-1s and weight loss and which ones are good. Even though semaglutide and tirzepatide are clearly the best for weight loss and everything. Again, getting back to that, we want this beta cell effect. The family I've been involved with recently with 1-alpha, who weren't responding great to the sulfonylurea, or maybe partially, it's dulaglutide that we've had them on, and it's been great. It's worked really well. So it's it's a great use for some of the other GLP-1s that we are not as happy with for the weight loss. This might be a great role for them with or without the sulfonylurea. But I wouldn't throw away the sulfonylurea entirely. I think there might be, a dual kind of effect. Although with 4-alpha, the sulfonylurea data has always been less convincing anyway. So I'm glad your patient has responded so well, though. That's ultimately what it comes down. It's great, and it's great to have this case as another example.
So I'm sure we could say more, but it's about the top of the hour. I appreciate everyone. And thanks to Dr. Hart, I saw the CEL. I totally had missed that. It's not coming up in my literature searches, so I don't know why that is, but now that we have it, we can add it to the group, and I'll put you on the list to make sure you stay updated. Well, as insofar as obscure things we missed by
Yeah, I
both.
was going to note that too, Lou, that I'm not, we did the gene curation for cell. I'm not even sure we found that paper. So we should go
Yeah,
back and
it
look
was
at
findable because a day or two later I got contact from Bergen. So
it.
Oh yeah, so
uh,
that's great. So they're on it. So,
it was buried somewhere. I mean, yeah.
it's just so interesting. I've been searching on it while we've been talking, and it's just not coming up. So I don't know why that is, but
I'm glad Bergen found it,
yeah.
and did they, I'm sure they were interested to learn about it, and I don't know if did they have additional thoughts about that?
Not really. It was a short back and forth dialogue, and they said, "Yeah, we agree. This has to be pathogenic."
Okay. Yeah,
It was
I mean, with that phenotype, like
mostly left at that.
that's what
Yeah.
it comes down to. And it's good to know what Mitch mentions about and Lou, I wonder with older patients with diabetes that I'm a pediatric endocrinologist, but do you do sometimes think about absorption and that kind of thing? And so maybe sometimes these things are being tested and maybe we should start, reminding people to be thinking about that and considering API.
Well, I mean, so just we can end with this. I mean, the data from the UK Biobank and from Geisinger and some other places suggests that people are being they could be labeled as type 2 diabetes, but they also have one of these mutations. So, especially with a higher BMI and maybe some insulin resistance, so you can have more than one thing going on, and there's the commonality of type 2 diabetes and insulin resistance or metabolic syndrome layered onto a mutation makes things even more difficult. But that's what we're just from from blanket sequencing and looking at all comers without worrying about phenotype, that's what is being picked up now. So excellent. So thank you so much. We hope to continue the conversation, and we will also, continue to think about this and put it together. Every time we do this, we learn.
Yeah, thanks everybody.
Thanks, guys.